Okay, because of time and all that. So again, good evening, everybody. Look at that, I'm bleeding again. Just from a never mind. Good evening, everybody. So today we're going to continue talking about diseases of the esophagus. Uh, Basically, we're going to round up on the diseases of motility or contractility of the esophagus. Then we move on to basically the sort of the traumatic part of the problems in the esophagus. Um, Previously, we've always been talking about problems with dysphagia and all that. When it comes to dysphagia, we have to consider two things: whether it is because of a mechanical origin or whether it's because of a motility problem, right? Or the peristaltic problem. And we've talked about GERD, we've talked about achalasia. What else did we talk about last week? Uh, we talked about esophagitis and all that. Uh, so basically, GERD, achalasia, and all those things, these are all motility problems. And last week we talked about how, when it comes to motility problems of the esophagus, they are basically divided into two forms of two forms of two forms of uh, two groups. So as to see two groups of problems, which is the hyperkinetic or hypermotility. Another one is hypomotility, right? Logically speaking, one is very contractile, the other one is rather slow contractile, right? So we've kind of talked about the hypo or even akinetic part of the motility problems of the esophagus. So this week we are going to cover the extreme forms of motility problems in the esophagus, and that is diffuse esophagus spasm, nutcracker esophagus, and jackhammer esophagus. But basically, what we're going to talk about today, they are almost the same. The difference between them are very little, and for it to be very clinically significant, it does bear some form of differences. There are some forms of just very minute differences between them, but to really emphasize on those differences clinically is not very significant, because basically the treatment and the way we diagnose it is pretty much almost the same. But regardless, I think it still bears some form of significance when we talk about all these diseases, all these hypermotility diseases of the esophagus. So as usual, we're going to talk. We're going to talk. We're going to have patients. We've been having patients all this time, uh, ever since we started, and so we are going to start with a patient. Because essentially when we graduate and start working, well, who we are dealing with are patients. Okay, hope everybody can see it. All right. Ooh. 27-year-old man. Am I reading the correct one? Nope. 52-year-old female. No name. Let's give her a name. Let's give her, let's see. Let's give her Victoria. I don't know. Okay, 52-year-old female, named Victoria, was admitted to a hospital with complaints of intermittent dysphagia and chest pain for a year. She had symptoms on the lower substernal area with swallowing large amount of water, which were accompanied by chest pain. Chest pain was sharp, non-radiating, and was relieved by transports of swallowed water to the stomach. These symptoms only occur when guzzling water and not by taking a sip of water or eating, meaning a large amount of water being swallowed instead of taking small sips, one at a time. The temperature of water did not show any correlation with her symptoms. Her past history was unremarkable. There was no family history of similar symptoms. She was of normal body weight and had no abnormalities on chest, abdominal physical examination. Endoscopy of the upper GI was performed in other hospitals, but there were no abnormal mucosal lesions. Then she was referred to our hospital for further investigation on dysphagia and chest pain. The barium esophagram showed no abnormalities. 24 hours esophageal impedance pH monitoring was performed, and there were no pathological regurgitation. High resonance manometry was performed to assess esophageal motility. On sitting position, 14 times of water swallowing in total was performed. The interval between each swallow was 30 seconds. The patient swallowed 5 ml of water from the first swallow to the 7th swallow. 10 ml from the 8th swallow to the 10th swallow, 15 ml on the 11th swallow, 12 ml on the 12th, 20 ml on the 12th swallow, 50 ml on the 13th. Okay, so basically, they're increasing the amount of liquid that she's swallowing as the number of sorry, one second. There's the guests. Need to stop sharing. I need to allow. Why is the meeting locked? I wonder. Okay, anyway. Let's continue. Sorry about that. So basically the patient, the manometry when we are performing, when the hospital is performing high resonance manometry, esophageal manometry, which I'm sure this is not alien to you, to everybody, because we've talked about it several times. So basically, what they're measuring is they're trying to increase the amount of fluid that she's swallowing, and the goal is for her to swallow 14 times, and as they progress into the 14th time, the amount of fluid that she's swallowing is increasing too. All right, so then she said she did not have any symptoms from the first to the 10th swallow, but started to complain chest pain and dysphagia when swallowing more than 15 ml. The more water she swallowed, the worse her symptoms got. She complained the most severe symptoms when swallowing 50 ml of water. Rapid propagation pressurization were observed at the second, fourth, sixth, and seventh swallow, in which pressurization front velocity measured 9 blah 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 respectively. Impaired deglutitive inhibition was observed at the 13th swallow, but peristalsis was normal. Except for the 13th swallow, all the swallows were associated with normal deglutitive inhibition. The mean gastroesophageal junction pressure was set 12.7. Okay, now we're going to talk about the first problem that I promised that we're supposed to cover, and that is DES, diffuse esophageal spasm, nutcracker, and jackhammer esophagus, right? So let's look at this patient, Madam Victoria over here. She said that she complains of intermittent dysphagia and chest pain for a year. Intermittent dysphagia and chest pain for a year. Remember, when it comes to dysphagia, the first line of investigation should be which one? Barium swallow or esophageal or your endoscope? What did I tell everybody last week? Which one should be first? Barium swallow or your endoscope, esophagoscope?
Esophageal.
Mm-hmm. Good. Okay, so by the way, before we continue, I would like everybody to have your fingers ready to press the unmute button, okay? Because I would like us to discuss or to be responsive and to see how we can help this patient, okay? And I'll probably will, refer to several things that we've covered before, just so as to know that we are still on the same page and so that you remember as well. If you don't remember, note of what, but please get back to them and please remember them. Okay. Now, so intermittent dysphagia. So the first line of treatment should be your scope, right? Instead of barium swallow. Of course, barium swallow bears its own significance, but your first thing first should be your scope. And chest pain for 1 year. Chest pain for 1 year. So you see, could it be an eye? Definitely not. Although the pain is localized on the chest. Of course, we need to characterize more. We need to find out more about the pain, where the pain is, and all those things. Basically, your Socrates, the way you characterize pain, right? So basically, you need to do that. But there's no much of characterization here because the question would only include what's significant. But of course, um, as normal physicians, as general practitioner, and proper functioning doctors, we need to ask as detailed as we can. She had symptoms on the lower substernal area. Lower substernal area. Again, you see this reflects more of an MI2 as well. When swallowing a large amount of water, which were accompanied by chest pain. Chest pain was sharp, non-radiating, and was relieved by transport swallow water to the stomach. These symptoms only occurred when guzzling water and not by taking sips of water. Okay, see all these things characterizing the pain. Okay, good. The temperature of water did not show any correlation with her symptoms. Now, remember last week when we talked about dysphagia, the two things that we the two next the step that we need to take next is to ask whether the dysphagia is due to solid food or liquid food, right? Or both. And that's number one, solid or liquid. Second, in what order, if it applies, right? Whether it's difficult to swallow solid first and then subsequently after a while it becomes difficult to swallow liquid, meaning when it's difficult for the patient to swallow liquid, it means that solid as well is difficult for them, right? What more to say logically, right? So now the third step is to ask whether whatever it is that they're swallowing, solid or liquid, what is that temperature? What is the temperature they're taking it? Is it hot? Is it warm? Is it cold? Because different temperatures affect muscles differently, right? That is why sometimes we need to use hot packs, sometimes we need to use cold packs and all those things when it comes to, let's say, when it comes to pain and all that, because muscles react to temperatures differently. What more to say, striated muscles that are more fragile, that are more malleable, that are more sensitive to temperature, not just the big muscles that we have externally for when it comes to the structural skeletal system that we have, right? As much as they are sensitive to temperature, what more to see to something that is inside and more thin, right? So of course, temperature is the next question that we need to ask as well. All right. So her past history was unremarkable. There was no family history of similar symptoms. She was of normal body weight and no abnormalities on chest abdominal physical examination. Endoscopy of upper GI tract was performed. You see, endoscopy is the first step. But there were no abnormal mucosal lesions. They put a scope in, nothing is seen. Nothing can be seen, no abnormalities. She was then referred to our hospital for further investigation on dysphagia and chest pain. Then you see next barium esophagogram is the next step. But unfortunately, it shows no abnormalities. No abnormalities. 24 hours esophageal impedance pH monitoring was performed. pH monitoring meaning to say they want to rule out GERD, correct? Because GERD, for the gold standard to diagnose GERD is your pH monitoring, correct? And there were no pathological regurgitation. No pathological regurgitation. Now, next is high resonance manometry. After all of that, manometry. Now, this investigation. The investigation is now getting more expensive. Was performed to assess the esophageal motility on sitting position, and okay, and then continue. We've talked about this already. And they found, and from the manometry, they found out that the higher the amount of the more the amount of liquid that they allow her to swallow, the more enhanced or prominent these symptoms become, right? And impaired deglutitive inhibition was observed in the 13 swallow, but peristalsis was normal. It means impaired swallowing was there's an impaired swallowing when the amount of liquid becomes more. Okay, and the mean esophageal junction pressure was 12.7. 12.7. Okay, so the first problem that we need to rule out from all of this, because you see that the endoscope is normal. The endoscope is normal, and barium esophagogram showed no abnormalities, and pH is normal. Now, then the problem can only be detected in manometry, meaning to say there is some form of problems when it comes to motility here, right? So when it comes to motility problems, esophageal motility, as much as we talked about the hypo or akinetic part of esophageal motility problems, there is the hypermotility part that we need to cover, right? The first one is DES, diffuse esophageal spasm. Next is hypertensive peristalsis or nutcracker esophagus. And third, hypercontractile esophagus or jackhammer esophagus, right? So these are the three main hyperkinetic problems in the esophagus. First one, diffuse esophageal spasm. From the name itself, diffuse, meaning that there is no specific localization, right? It means that it's uncoordinated. It's very erratic, uncoordinated, uncontrolled spasm or contraction of the esophagus. It means that as much as we would like it to contract and relax following peristalsis, the contractions are erratic, and they don't coincide. They don't always coincide with the movement of liquid or fluid or liquid or food when it enters the esophagus, because peristalsis essentially should coincide with the movement of things inside the esophagus, whatever it is, food and whatnot, right? But in DES, it's erratic. It's not. It is not. It does not coincide with the food, and also it's uncoordinated, right? In nutcracker esophagus or hypertensive peristalsis, the contraction of the esophagus is coordinated here. It is not erratic, it follows normal peristalsis. But the contraction is higher than normal. Is higher than normal. If the contraction, let's say, is 10, it's maybe 15, 16, 17. I don't know what the unit is in manometry and stuff like that. Maybe millimeter mercury and all that when it comes to pressure, right? Or maybe Pascal, I don't know. But basically the idea is that in nutcracker esophagus or hypertensive peristalsis, it is coordinated. It still follows your food or whatever it is that enters your stomach, your esophagus, but it is just um, higher. The contractility power is higher than normal. Next, in jackhammer esophagus, it is almost like nutcracker esophagus, but the contraction is double or more than that of nutcracker esophagus. Meaning to say it is the contraction is so strong. Still coordinated, but it is very strong. It's called hypercontractile esophagus or jackhammer esophagus. So essentially, understanding all of this, it means that one is very erratic, uncontrolled, like a kid, running up, like a naughty kid running up high and low, and it's uncontrolled, and then you can see parents running up and down trying to chase the kid. The other one is like an ironclad dictator, very strong contraction, and everybody is just following that contraction, just bowing down to that big boss up there. So that's basically the two main difference. So how do you diagnose this problem, right? Sometimes or most of the time, the or even all the time, endoscopy will reveal nothing because the problem is not intraluminally, it's not in the lumen of the esophagus. The lumen, everything is intact. That is why I see in this patient right here, Madam Victoria, 52-year-old over here. Her endoscopy shows no lesions at all, although there is an indication to do your scope because of dysphagia, right? So the next thing is barium esophagogram, right? So you put a contrast and you see the movement of it, right? Basically, it's not a static um, X-ray. It is a very dynamic X-ray where we see the movement of it. But technically speaking, if you see that, you can actually detect abnormal contraction of the esophagus, right? Technically, you can. So barium esophagogram can actually help you to diagnose that, and it is actually quite a good modality to refer or to fall back to when it comes to diagnosing DES. It comes to diagnosing DES because it's very erratic, right? So when you see um, that the esophagus is not straight, you see a lot of waves. They call it corkscrew esophagus in on X-ray picture, not in like the phenomenon like nutcracker. They call it cork on X-ray on in radiography in that language, the radiography language, X-ray language. They call it corkscrew esophagus. So you see when you can see that it's very wavy and all that. So you can see that, but in your nutcracker esophagus, your hypertensive peristalsis, and or your hypocontractile esophagus, you can't see that. You can't really diagnose it just from barium esophagogram because the contractions are quite coordinated, right? And you you can't say, oh, this one is the contraction is stronger than this one, the contraction is stronger than this one. You can't say that because the contrast does not tell you how strong that contraction is. The contrast does not speak to you, telling you that, oh, this is very strong, this is very strong. No, cannot, right? So for those two forms of hypermotile esophagus, barium esophagogram may not be helpful. That is why the kind of best modality when it comes to confirming the diagnosis of hypertensive peristaltic esophagus and hypercontractile esophagus, you will need manometry to confirm. That is the best one because everything is very objective, very very straight to the point. It's very evident because the numbers are there, right? Okay. So from here, you can see that the barium esophagogram showed no abnormality. But then in hyperresonance, high resonance manometry, you can see differences in that, right? So with all that I've said earlier on, what is your diagnosis here? What do you think is the diagnosis here? What do you think Madam Victoria has? Anyone? People tell you to put your finger on the mic. You.
Not quicker reject my mark.
What?
Automotivity esophageal disorder.
Which one? Hypertensive or hypercontractile?
Hypercontractile.
Okay, anybody else with a different opinion? It can be hypertensive peristalsis too. Possible? Possible, right? Now, because there are no numbers, not enough numbers here, you see that the pressurization is just 19, 8, 42, and 34 centimeter per second. This is just velocity. It does not show the strength of the contraction, which is why, because we now need to differentiate, we need to be sure whether this is hypertensive peristalsis or hypercontractile esophagus. We need to see a graph. Oh, by the way, if it's DES, this is how it should look like. This corkscrew esophagus. This is not cracker esophagus, by the way. Okay, now this is what we are going to look at. All these graphs. Don't be scared, I'll explain the graph. Pretty simple actually. Since most of us have already done ops, I'm sure this won't be something difficult for you to understand. This looks like your CTG machine, no? Right? This looks like your tocogram. In your CTG, you look at the contraction of the uterus and you look at the fetal activity, right? And the higher, if it coincides and the higher it is, you can estimate that the mother is in labor, correct? But here is not, of course, the patient not be in labor here because it's the esophagus. But the idea is the same. The idea is the same. You see, this is a normal manometry reading. Normal manometry reading. Okay, this is a normal manometry reading. Here is the one that's spiking is the one that's holding food, and then normal, then spiking again. This one over here is hypertensive peristaltic hypertensive peristalsis here. What's the difference between hypertensive peristalsis and normal one? The criteria is that you see it all coincides, right? Sorry. 1, 2. Are there any other? I should show DES. There's no DES here. Ay. Sorry. I think I forgot to put DES in. Okay, anyway, this over here is your, wait 1 second. I do. Okay, sorry. Confusion again. This is normal, right? I talked about normal. This is your sorry, not hypertensive peristalsis. This is your hypercontractile esophagus. You see that the contractions, they are all the same. They coincide with each other, but it's very, very tall. See, goes up here, goes up here, right? So the criteria to see that this.
Can't see the full picture.
What?
Okay, yeah. Continue.
Okay. Can you see the picture? Maybe just zoom closer, maybe. Okay, so here over here, you see that this one is very tall. Very tall, yeah. 1, 2, 3. Okay, so the criteria to confirm that this is hypercontractile esophagus is that the height of the contraction is at least twice the normal. Twice the normal. Of course, you are not going to be the one who is going to perform it. The person who is more familiar with the device and system would be the one doing it. But if you are tested in board exams and or maybe ask during in the hospital, is that the contraction is at least twice than normal in at least 2 swallows. If you want this patient to swallow 14 times, then 2 out of those 14 should reveal abnormalities. At least 2. If 1, not really. So at least 2, and you see that the contraction is at least twice stronger than normal. This is normal. This over here is DES. The contraction is very erratic, you see? Just very random contraction. Some of them are tall, some of them are not, and all that, very erratic. There's no control, whatnot. So this is just this is like your third degree bundle branch block, not bundle branch block, third degree AV block. Sorry, third degree AV block. There's no control whatsoever, and everything is just very erratic. So this is your DES. Okay. So the treatment for patients with DS, not correct, DS, hypertensive peristalsis and hypercontractile esophagus is the first line should be your calcium channel blockers. Any calcium channel blockers would do the trick. Nothing specific here. Next would be nitrates. Next would be nitrate, calcium channel blockers, nitrates. Next would be Botox, botulinum toxin. We talked about last week, achalasia, how botulinum toxins work, right? It contracts, it relaxes the muscles and all that. And of course, when it comes to Botox, you need to re-inject every 6 months because that's the the duration of effectiveness of Botox. More than that, it's no longer effective. Some people would argue that sildenafil can be effective, right? If because essentially sildenafil is although of course you don't use sildenafil just for DS, I'm sure I think most of us have heard of sildenafil. If not, you probably have heard of Viagra. Viagra is sildenafil. Of course, you know that Viagra is used for erectile dysfunction, right? But the problem here is almost the same. Well, the problem is the muscles and all that. So some might argue that sildenafil may be useful. So these are just pharmacological treatment. If you would like to do um, surgical treatment, you can do dilation. Of course, when it comes to dilation, there's always risk. Last week we talked about how dilation of the esophagus can lead to tearing of the muscles and risk for reflux diseases, right? Myotomy, we can perform myotomy. We can resect or just reduce the influence of some of the nerve endings there in the esophagus, so as to not make the esophagus contract very often. And yeah, so all these are mostly surgical, and it's no longer up to us to decide on that. So those are just basically the idea behind it, right? Okay, let's see if there's anything else. Oh yes, this is a very old case that I found. It's 1991. Here, just want to show you, this is also your DES. This is your DES. 52-year-old female college teacher.
Can't see anything.
You can't see anything? Really?
Nope.
Dark. Can you see it now?
Yes.
Okay. So this is a very old case. This is a case of DES. 52-year-old female. No name again. We should give them a name. Let's call this 52-year-old female Queen. Okay, Queen, a college teacher, presented to the outpatient department. Severe crushing chest pain after meal, sometimes on empty stomach. Everything else is normal. No weight lost. Yeah. Whoa, what am I reading? Oh yeah, no weight loss. Barium swallows showed marked segmentation of barium in the esophagus, suggestive of corkscrew esophagus. See, okay, pretty straightforward. So this is DES, right? Lower esophageal sphincter pressure of 26.1, incomplete relaxation on wet swallow. All these things are quite old already, so I'm not going to read them out loud anymore. So they don't really use these things anymore. But I just want to show you the DES over here. Here is a very old and terrible picture. You can see how old this is already. It looks like the ECG strips that we get in proper. No box whatsoever. I cannot see whatsoever. You see over here, it's very erratic. If you can see, I hope you can see it. Very erratic over here. Very erratic. So this shows your again confirming DS. 35-year-old male. Dysphagia, mild retrosternal pain. Provoked by swallowing. Pain provoked by swallowing. So, you see, pain provoked by swallowing is odynophagia, right? Remember, when it comes to dysphagia, it is your scope, but odynophagia, you use barium swallowing. Okay. And case 3, shopkeeper profession with 1/2-year-old epigastric retrosternal pain. Proton pump inhibitor was normal. All of these are DS. Final diagnosis of DS was made. Final diagnosis of DS was established. Okay. Clear? Any questions with DES, nutcracker, and your jackhammer esophagus?
It's fine because their diagnosis,
Hmm?
like their investigation. Can you recap?
Investigation.
Yeah.
Investigation for DES best will be barium swallow. Simple investigation, of course, you can do your manometry as well. It will be more objective and more clear because everything has numbers. But first initial step of barium swallow is enough to see it. But if it's not significant, then it means it's either your nutcracker or your jackhammer esophagus, right? But as much in this case, as much as dysphagia is present here, when we do scope, it does not reveal anything. It does not reveal anything. So you need to think, if this is a hypermotility problem, then of course your usual one would start with your scope. But if you are sure enough that this is a hypermotility problem, then you don't have to send the patient for a scope, because you'll be wasting money and the patient will be angry at you for sending a lot of investigation. But okay, first for DES, best one barium swallow, manometry. In hypermotility, in nutcracker, best one is your manometry. The rest of investigation is not very specific, not very significant. Your lab findings, your blood tests, all those things, they are not specific at all. Of course, you need to rule out some things that can provoke spasms, and most of the time these spasms are quite, the etiology behind it is not really quite known. But there are some diseases that can provoke spasms and problems with neurons and all that, neuropathy and all that, be it diabetes and all that. So you need to find out your levels of glucose and your glycosylated hemoglobin, your HbA1c, all those things. Of course, you need to do that just to rule out, but those are not very specific. But if you want to confirm it, just these three things. Okay. Any other questions before we move on? Okay, now it's 7:46 already. I think I might extend it. I know that I said that I'll try to cover everything in 1 hour, but I don't think I'll be able to finish everything in 14 minutes. So I'll extend it to 8:15, okay? But technically, it's still within our usual time of 1.5 hour. I hope that's okay. Okay, so if there are no questions with that, so that concludes the motility problem of the esophagus. Let's now talk about the next thing, and it is the esophageal rupture and tear. Esophageal rupture and tear. The thing about esophageal rupture and tear, what we need to know, pathophysiologically and anatomically, is that the esophagus itself is a very fragile organ of the GI tract. It's not like other parts of the GI tract. It does not have a serosal layer. Does not have a serosal layer. It does not have that extra connective tissue layer that can help to protect or give support to it. Therefore, anything that damages the lining of the esophagus, be it intraluminally or extraluminally, it can be quite traumatic to the esophagus in comparison to other organs of the GI tract, be it the stomach and the intestine. Definitely, intestine is a very it has a large caliber and therefore can quite withstand some form of trauma, be it mechanically or anything else. So with that said, it means that whatever it is that irritates the esophageal esophageal mucosa, it can be very um, damaging. Like when we talked about GERD and when we talked about peel esophagus based esophagitis, right? We talked about all these different things that can cause esophagitis. We understand that the lining is very sensitive. So what more to say when it comes to tear and rupture? Even the the mucosal layer is very sensitive. What more to say something that's deeper than that, right? A tear or a rupture. And most of the time when it comes to a tear or rupture of the esophagus, it can be caused by a lot of things, but the most common cause of esophageal tear or rupture is iatrogenic. It means it's caused by us, medical people, be it a scope, be it a surgical procedure, be it an injection, be it um, any investigation, giving barium swallow, um, anything that enters the esophagus, it's unfortunately tears and rupture. A lot of about 85% amongst all causes of rupture and tear of the esophagus, it's because of us, unfortunately. And we have to bear in mind that because of that, we as the medical professionals, we have to understand, we have to explain the risk and of whatever it is that you want to do to the patient, so that the patient does not come back to you telling you that why did you do this to me, right? Understanding this and making sure that the patient understand this as well is also important. The next thing is um, the next most the next common cause is foreign body. Foreign body. Kids swallow a lot of things. We swallow a lot of things. People who eat fish swallow bones of fish, can be quite damaging. Thank God I don't eat fish, or not. Thank God I don't like to eat fish at least. But then again, other bones can enter the throat as well, right? Your chicken bones, what bones, and all those things. So foreign bodies. Next is trauma. Trauma. Next is excessive vomiting. Excessive vomiting. And we'll talk about tear and rupture when it comes to vomiting, because it's getting more and more prevalent as more cases appear now of of esophageal tear and rupture because of vomiting. And when it comes to esophageal tear and vomit and rupture, caused by excessive vomiting or just a very massive pressurized vomiting with the closure of the glottis, it is common for us to hear Mallory Weiss syndrome caused by this, and Boerhaave syndrome as well. All right, the symptoms of tear and rupture, it varies. Some people might have just dysphagia. Some people have odynophagia without dysphagia. The difference is that the patient can swallow normally, no difficulty in swallowing, but it's just painful to swallow. There should be a distinction between two of them. And the rest of them, of course, when it comes to tear and rupture, there'll definitely be bleeds. We talked about upper GI bleed, right? And signs of upper GI bleed. And we talked about hematemesis. We talked about melena, both of them characterizing upper GI bleed. Hematemesis meaning that the bleed is the bleed per os is bright red, right? And melena, it being black tarry stool, correct? Because it has gone through the gastric acid, and well, it takes time for it to go out per rectum, so that is why it's dark and all that. Besides that, there is this triad called markless triad. Let me type that out. Markless, M-E-R. Markless, A triad. Markless triad. This includes vomiting, chest pain, and subcutaneous emphysema. Subcutaneous emphysema. About half of patients with Bohart syndrome gets Marcus triad, and the other half don't. So to make it very specific to Bohart syndrome, it's not very accurate as well, because you can see that in different diseases, not just Bohart syndrome, but also, let's say, foreign body or trauma of the esophagus. There's a rupture, there's a complete tear on the esophageal wall, and not necessarily due to vomiting, because Bohart is due to a lot of vomiting, right? Okay, now the difference. Let's talk about tear. The difference between Mallory Weiss and Bohart syndrome. Both of them is because of excessive vomiting. Although Mallory Weiss is very highly associated with, there's a causal link between Mallory Weiss and the intake of alcohol, excessive alcohol binge, and the next day or the night right after the party, or just the very next day, the patient vomits a lot, getting hangover and all that, and starts vomiting a lot and starts to bleed for us. And because of that, the tear, the small multiple minute tears at the esophageal gastric junction, especially at that junction, right? Because it's not ruptured, right? They're just torn a little bit, then it starts to bleed. And the difference between Mallory Weiss syndrome and Bohart syndrome is that Bohart syndrome is a rupture, meaning to say it is transmural, whereas a Mallory Weiss, it's non-transmural. It's not transmural. It's just basically superficial. Whereas in Bohart syndrome, it's a complete open. Meaning to say, in Bohart syndrome, because the tear or rupture of the esophagus is transmural, it means that there's a possibility of the gastric content to get out, right? Wherever it is, be it in the thoracic cavity, meaning to say it can get into the pleura, can get into the pericardium, or if it leaks exactly at the junction at the LES, lower esophageal sphincter, meaning to say there is a chance that it can enter the peritoneum. There's a chance that it can enter the thoracic cavity. So with that said, in Bohave syndrome, the most common place of it happening is the left side and at the lower part of the esophagus. Why, I don't know, but most of the time it's left and lower part of the esophagus. Now, because of that, um, because there is a fistula or a connection now because of the opening between the esophagus and the pleura or the thoracic cavity or into the mediastinum. Because the esophagus also carries air and it enters there. When we perform X-ray, we can see that in the mediastinum, we can see some translucent or transparent shadowing, meaning to say that there's gas there on the left lower part of the mediastinum. I mean um, that shows Bohave syndrome. It's more commonly seen in males as well, and patients who vomit a lot, especially when they vomit. Before they vomit, the glottis is closed. Then once only when when the vomitus reaches the glottis, only then the glottis open, meaning to say a very strong pulsive force of the vomitus and the esophagus, because it's very thin, like what I said earlier on, it's very fragile, cannot withstand a lot of things, very weak, so it opens. Okay, so that's basically the idea behind Bohave Bohave syndrome. Let's now see some patients. Oh, by the way, when it comes to medullary ways, the it's very unlikely for patients to feel pain. Although there's bleeding and all that, there's no dysphagia in medullary ways or adenophagia, but there is bleed. So the upper GI bleed is painless. That's the dangerous part of it. But the good side of it is that the problem in medullary waste can resolve spontaneously a lot of the times. Let's see. All right, 32-year-old indigent man. Let's give his name. Let's call him James. I don't know why. Okay, let's call him James. 32-year-old indigent man named James was brought to the hospital by the police. Very nice that the police here brings people to the hospital instead of beating people up, right? In an altered state of consciousness and in respiratory distress. During the short interview period, the patient described 8 hours of multiple emetic episodes with hematemesis and some chest pain. 8 hours of vomiting. And then starts to vomit with blood, together with chest pain. Chest X-ray showed a large left pleural effusion, which led to a thoracostomy to obtain cloudy material. Given this finding, a CAT scan was performed. It showed a collapsed lung with a collection of material of heterogeneous appearance. Patient's general condition was progressively deteriorating, so he was taken to surgery. Poor James. Since the patient has hematemesis, an upper GI endoscopy was performed before surgery. It showed large hole in the left wall of the distal esophagus. During preparation of an open thoracostomy, it was decided to enter through the perforation. A collapsed left lung was found with large amount of contaminated material occupying the left hemithorax and pericardium. Even traces of food could be seen. So they put the scope in the esophagus and they saw a hole. Then suddenly, they decide to go through the hole, to enter the hole, and to see what's outside of the hole, right? So this is the X-ray picture. Chest X-ray. Note that left pneumothorax compromises 50% of the lung, preserving a preserved cardiac silhouette. You see that the shadowing is different already, right? So obviously the left lung is definitely already collapsed. You see that the mediastinum is also shifted to the left as well. See, very big. But the heart silhouette is, oh, this is a very good X-ray. The heart silhouette is still quite clear. This is a CT scan. It says here, a collection of heterogeneous appearance of compromised left hemithorax. This is the endoscope. This is the normal esophageal lumen, and this is the hole that they decided to go into and to see what's inside of the hole. After going into the hole, they look into the hole and they see that through the perforation, they see that the lungs is collapsed. You see a collapsed lung mark on the straight area. This is the lung, and the heart is to the right. Food remnants can also be seen in the entire field of vision. So, with all of this said, it's quite clear that this is Bohov syndrome, right? There's a huge tear, and he has compromised the lung, compromised the heart, and all that. And so this is the thing that we need to, they always come together with Bohov syndrome, because it creates a communication between the esophagus and different cavities, both the chest cavity and potentially the abdominal cavity, and it affects a lot of different organs as well. And you see that it affects the lungs, right? Okay. Obviously, the treatment for this is no longer pharmacological, no longer conservative. Of course, you need to give antibiotics and all that, but the treatment here is surgical. I took this, I don't remember where I took this from, but this is a real patient. Unfortunately, the patient died. They fixed the hole. They gave him very intensive broad spectrum antibiotics, but he did not survive all of that, because the lungs and the heart was already severely compromised and he could not make it. Okay, next. 82-year-old female. Let's give her, what's her name? Let's call her Apple Pie. I don't know why. Okay, Apple Pie. 82-year-old female. Outpatient who had clinical symptoms of dysphagia when trying to swallow solid food. You see, quite specific. When trying to swallow solid food, and weight loss, underwent upper endoscopy, showed an upper esophageal lesion with compromised 50% of the passage. Biopsy showed that the middle and distal esophagus were normal with an intact Z line. Following the procedure, patient complained of adenophagia and an hour later presented multiple episodes of gagging and hematemesis with evidence of mild respiratory distress. The chest X-ray showed left pneumothorax. Patient was sent to surgery, and endoscopy prior to surgery showed the presence of a lesion and bleeding stigmata due to the biopsy. We advanced 27 centimeter in until the endoscope reached a large perforation in the left wall. The perforation probably occurred because the patient could not expel air from the first endoscopy, as the edema produced by biopsies prevented adequate cricopharyngeal relaxation. See, again, iatrogenic here. Primary wound was closed, and then radiation therapy was used to treat the original lesion, which was squamous cell carcinoma. Squamous cell carcinoma, ladies and gentlemen, of the esophagus. Where is it usually localized? Proximal third or distal third? Which one?
Third.
Distal third or proximal third of the esophagus? I heard distal third.
Yeah.
Anybody wants to say proximal? Yes? Proximal or distal? Those who said distal, why? Those who said proximal, why?
Distal because the esophagus is covered by the columnar epithelium, and then it got replaced by the stratified epithelium of the stomach, and then CA. Okay, something like that.
Okay. Anybody with a different point of view? No? Okay.
Same explanation, but at the proximal
Same explanation but proximal.
location.
What? Can you repeat again?
Say it's at the proximal third and with the opposite explanation.
Proximal third with the opposed explanation. Okay. Anybody else? Okay. If nobody else, I have a different point of view. First and foremost, the lining of the esophagus is originally lined in a healthy patient with squamous cell, not columnar cell. But in the GI tract, in the stomach, in the intestine, they are lined with columnar cells.
Okay.
Why? Because they are glands. Glands are usually columnar epithelium and not squamous. That is why in Barrett's esophagus, especially in long-standing GERD, which then develops, which which then you might see metaplasia of the epithelium of the esophagus. It means that there is an exchange, right? Like what you said, an exchange of originally squamous cell being replaced by columnar cells, which they call it the intestinalization of the esophagus. That is why for squamous cell carcinoma, it is mostly in the proximal part of the esophagus because the problem with GERD is mostly in the distal part. So at the distal part, we most often see, if there is cancer, we most often see adenocarcinoma because the epithelium is no longer squamous. It is now columnar, which is glandular, right? Glandular in nature, which is adenocarcinoma. So here, the patient, what was her name again? Apple Pie. Madam Apple Pie has maybe had squamous cell carcinoma. And the groups of people who are predisposed to it are alcoholics and smokers. So, meaning to say that the problem here is proximal in the esophagus, right? But you see that there is a hole, and a lot is history of vomiting. Endoscopy, you see that there is an infiltrative mass, edema. And you see distal esophagus, you see to the left is the large esophageal perforation marked by straight arrow. This is the hole, and this is the lumen, right? And this is the esophageal junction to the stomach. So this is the hole. Remember, in Bohab syndrome, it's most often to the left, direction to the left at the lower side of the esophagus. So again, so the diagnosis here is Bohab syndrome. Okay. All right. Oh, it's 8:15 already. Let's go through this last patient over here. I said 15 minutes and here we are talking again. 27-year-old man. Let's call him Mr. Ivan. Ivan Ivanovich presents to the emergency department with 2-day history of hyperemesis followed by episodes of hematemesis. Worsening epigastric pain, diarrhea, myalgia. We do it very quick, okay? Night sweats, rigor, no melena, no hematocresia reported. Binge drinker, drinks a lot of beer, and consumed approximately 21 cans of beer 3 days ago. 21 cans is a heck load of beer. One beer is like what, 300, 500 mil? 21 is like 6, 7, 8 liters, and that's like what? The amount of blood that we have in our body. I don't know how much blood do we have in our body anyway. Anyway, the patient's relevant past medical history includes esophagitis, which was diagnosed last year and was treated with long-term PPI. He had no known drug allergies and has not taken any other medication, does not admit to using any illegal substances. Oh, I like what it says here, how it's stated here. Does not admit. No, nothing confirmed. Okay, he does not admit to using any illegal substances. He has a significant family history of hokum. He works as a laborer and has smoked 10 cigarettes a day for the past 6 years. Soon after presenting an ED, he collapses. In PE, temperature is subfebrile, tachycardic, you can say normotensive, severely dehydrated, tenderness to palpation at the upper chest and neck. Lung is clear to auscultation, heart sounds are normal, no murmurs. Lab results increase white blood cell, you see that the sodium is a bit increased, potassium is decreased, urea is normal, creatinine is 0.001 increase, liver is increased, your GGT is increased, ECG shows QT interval, ST depression, diagnosed with multi-organ failure by sepsis and transferred to highly dependent unit. Vigorous fluid resuscitation, broad spectrum intravenous antibiotic, reveals the S vomited 30 times vomiting for the past 27 hours. Okay, so chest done, CT done. Okay, so this patient, of course, is quite, it's not really clear yet. I don't think there is enough investigation to confirm that this is Bohaf syndrome Mallory waste, but because you see that this patient is a binge drinker, it means that there's a chance that he might be drinking before. So it could be Mallory waste. It could even be Bohaf syndrome because you see 30 times already vomiting 30 times, and you see that the signs and symptoms are very severe, more severe than what you would expect in Mallory waste. You see that he has multiple organ failure, sepsis, and you see that the white blood cell is already increased, that you see that there's a need for fluid resuscitation, there's a need for IV antibiotics, and you see that the liver function is already increased, and you see that he's hypokalemic already. So with all of this, you see that the condition is quite severe. So most likely this is Bohaf syndrome too. You guys are following me? Following my train of thoughts? Okay.
Yeah.
With that, we need to look at something else as well. You see that the patient, although been drinking a lot, you need to think of other things as well, because the patient has history of alcoholism. It means that the liver might just be compromised regardless. So your GGT may be increased because of the alcohol and not because of the bleed. So because of that, you need to rule out liver cirrhosis as well. You know that in liver cirrhosis, there's an increased chance of portal hypertension. And portal hypertension, you know, when it comes to portal hypertension, we'll talk about esophageal varices. And when esophageal varices rupture, that results to upper GI bleed. Instead of Bohaf syndrome, rupture of upper GI bleed and rupture of esophageal varices can be quite severe too, can mimic a very severe onset of symptoms as well. So you need to rule that out as well. Okay, let's see what else again. Esophagitis as well. Esophagitis may be because of reflux and all that, or caustic. Remember we talked about some agents can cause esophagitis as well, and proton pump inhibitors. The hokum, not much of hokum. Although you see he smokes 10 cigarettes a day for the past 6 years. 10 cigarettes a day, again, that kind of puts him in a place where there's a chance that it could lead to esophageal carcinoma, although 6 years and 10 cigarettes a day may not really be long enough to cause cancer, although cancer should be ruled out regardless. You need to do endoscopy and biopsy to confirm that. But if there is cancer, the signs and symptoms may not be so insidious, and you see that the signs and symptoms are quite insidious. So you can kind of that should not be on top of our priority. But regardless, we can rule that out as well, because there's a risk for esophageal carcinoma here. Epigastric pain. Epigastric pain. You need to rule out peptic ulcer as well, of course. Night sweats and rigors. Because the thing about peptic ulcer is that if it is Helicobacter pylori caused, it means that there's a chance that the bacteria has entered the peritoneum and all that, and it could mimic the sepsis. Could mimic that as well, especially if the patient is in septic shock. So you need to rule that out too. Okay, so you all get the idea, right? But most probably this is Bohov syndrome. I'm sorry if I talk too fast. I hope you got me. Was it too fast for everybody? Okay, anyway, if it's all right, if it's too fast, there's always a recording to fall back to, and you can just play over and over and over and over. I'm sorry for speaking too fast. All right, any questions? No? Хорошо. Тогда next week, what's left is Zenker's diverticulum. Zenker's diverticulum is quite simple, honestly. Pharyngeal pouch, esophageal diverticulum, Zenker's diverticulum, basically very, very simple. So I think that we can cover that very quick next week, and probably we can start with problems in the stomach. Congratulations, we've talked about esophagus for one whole entire month. We can move on to the next organ. All right, so with that said, thank you for joining us today. By the way, today is also marks kind of a full month of using WebEx. I've renewed the subscription to it. So next month we'll still be using WebEx. I hope that's okay for everybody. So far the experience is quite okay as well, and I like it, and we'll continue using WebEx so far for as of next month. So again, if anybody wants to chip in, feel free to do so. Don't make it mandatory for everybody to chip in as well. All right, so with that said, have a nice evening. See you guys next week.
Thank you very
Bye-bye.
much. Good night.
Night.